Obesity and cardiovascular risk. As we can see, obesity in Europe is an important risk factor. And you can see here that in countries like Greece, like Russia, like Bulgaria, 40% of the population are overweight or obese. And you can see also that the overweight population is more than 50% of the population in Europe, and this data is from the latest Euro statistical analysis, and this is an important problem of the future. Obesity is going to be the #1 risk factor for cardiovascular diseases in the next coming years. So obesity is associated with diabetes. In patients that are obese are having 10 years risk for type 2 diabetes 15 times higher than normal weight ones, and also are having increased probability for hypertension. 10-year risk for hypertension in an obese patient is 2 times higher than normal weight ones. Other factors that are also associated with obesity is increased cholesterol levels, decreased HDL, increased triglycerides also at the same time. These patients are also having other problems like gallstones, like colon cancer, like stroke, and cardiovascular disease in 10 years, suggesting that obesity is associated with all the cardiovascular, and not only cardiovascular, all the causes of mortality that increase patients with obesity. You can see here from the MENS study that obese patients are having hypertension in almost 40% of the obese patients compared to non-obese subjects, and also are having low HDL. From early studies from my group during the first years of my career here in Thessaloniki, we reported that obese patients had true hypertension, suggesting not only hypertension at office, but also outside of office with 24-hour ambulatory blood pressure monitoring, twice as compared with normal weight subjects. As you can see here, that the true normotensive in obese population were 20%, while white coat and true hypertensive were increased compared to the normal weight subject. Similar results in children and adolescents from Stella Stambouli group showing that that children with obesity had increased systolic blood pressure during day, but as you can see here, also during night time, suggesting that these problems start early in life. Several of the mechanisms that are associated with obesity, with hypertension in obesity, as we can see here, the adipocytes are producing either hormones like leptin or other factors like inflammatory factors, IL-6, CRP, TNF-alpha, reactive oxygen species, also produce angiotensinogen, and these all these factors with as we can see here, with many mechanisms can induce hypertension in a patient that are obese. And also obese patients are having an increase in heart failure. It is true for obese women that are having at least twice the time of probability of having heart failure in the future. Left ventricular hypertrophy was also reported from the Milan group that is more probable in patients that are having metabolic syndrome. And you can see here from Alberto Giacchetti and co-workers that diastolic dysfunction is also increased in patients that are obese, suggesting that these patients are having intolerance when they are having exercise. Patients with metabolic syndrome are having increased the probability of having diastolic dysfunction. Obesity and daytime blood pressure were the predictors of left ventricular hypertrophy also in true normotensive patients. In patients that are normotensive, also are in office and out of office without 24-hour ambulatory blood pressure monitoring, have increased the probability of having left ventricular hypertrophy. You can see here in true normotensive that obese patients are having twice the probability of having increased LV mass index and increased probability of having left ventricular hypertrophy. You can see here that the hypertrophy of the patients that are obese are different from that that are hypertensive and lean. You can see here that in obese patients, the majority of the patients are having eccentric hypertrophy, and we know that in patients with hypertension, there is mostly concentric hypertrophy in their heart. So obesity is inducing mainly eccentric hypertrophy in the patients that are obese and normotensive. Similar results in carotid arteries, intima media thickness of carotid arteries were increased in obese patients compared to normal weight subjects. You can see here that there is a linear association between obesity and the presence of increased intima media thickness and plaques of patients that are obese. So we thought that obesity could be an important factor, and several years ago in the working group of obesity from the European Society of Hypertension, we started to say that obesity is the cause of all cardiovascular diseases. And if we treat obesity, then we can reduce the probability of hypertension, and we also can reduce the probability of having type 2 diabetes. You can see here in stage 1 hypertension or low total cardiovascular risk, the patients can reduce their body weights either with lifestyle modification or with drugs, and this can be acted to the blood pressure of the patient. So reducing the body weight, we can reduce also the blood pressure. And these drugs were also can reduce the body weight and at the same time the blood pressure of our population. We can suggest also that these patients can be treated with drugs that are not having a metabolic effect to induce increased lipids or type 2 diabetes. So ACE inhibitors, ARBs, CCBs, and the low-dose diuretics are the first step of treatment of obesity hypertension, while other drugs like older beta blockers or other drugs like diuretics in high doses can be postponed in the treatment of patients that are having obesity and hypertension at the same time. What about obesity and diabetes? Diabetes is going to be also the first problem in Europe the next 25 years. And 60 million people with diabetes in the European Union are going to be 10.3% of the population the next years, the patients that are obese and having also diabetes. And the prevalence of diabetes is increasing among all ages in the European Union, mostly due to increases in overweight and obesity, unhealthy diet and physical inactivity. Overweight and obesity is estimated to account for 65 to 80% of the new cases of type 2 diabetes. You can see here that if we treat the cause is obesity, then we can reduce the new onset of diabetes in the future. And the risk of new diabetes is a function also of age, duration of obesity, and weight gain. There is, here you can see the mechanism of how obesity is causing diabetes. You can see here that the hypertrophic adipose tissue in obesity is inducing inflammation through macrophage activation, and this macrophage can induce increase in free fatty acids, lipotoxicity in the liver, induce increased hepatic glucose output and non-alcoholic fatty liver disease, induce lipotoxicity in the muscles, reducing insulin-mediated glucose uptake, insulin resistance, and also at the pancreas induces beta cell apoptosis and reduced insulin secretion. And this is the main mechanism of type 2 diabetes in patients with obesity. You can see here that there are now trials available, like the direct trial, that using very low caloric formula diets. You can see here that these patients were treated with a formula with no more than 800 kilocalories per day. So they are having a very low caloric intake during the 24 hours, can induce reduction in body weight, but you can see here that we can reduce the body weight about 10 to 50% to 15% of the initial body weight. At the same time, when we are reducing body weight, we are having also a reduction in the systolic blood pressure, in the triglycerides, in also in reducing A1C, an increase in HDL cholesterol, no significant results in LDL cholesterol, and a reduction also in diastolic blood pressure. All the major cardiovascular risk factors were lowered with the reduction of the body weight in patients in the look-ahead trial. So a modest weight loss seems to be necessary to reduce A1C levels in patients that are diabetics in look-ahead trial, but these patients are going to regain about 30 to 35% of the initial body weight in the next year, suggesting that this is a temporary measure, and we can have more. We should do more than this with the treatment of the patients. Not staying only in lifestyle modification. Lifestyle modification is important, but also we have new drugs that we can use for the treatment of diabetes, and we have the gliflozins, EMPA, DAPA, and CANA, and GLP-1 analogs that can be used in patients with type 2 diabetes. At the same time, these drugs are reducing body weight and are important in patients that are having at the same time obesity, hypertension, and diabetes. This is the holistic approach for the patients that are obese and having these risk factors. And with lifestyle modification and the treatment, we can have at the same time reduction in body weight and also these metabolic factors. What about obesity and dyslipidemia? Obesity also associated with dyslipidemia. You can see here the major mechanism. Inflammation again is the major mechanism. You can see here that adipose tissue lipolysis inducing increased free fatty acid levels, and this induce increased VLDL, reduce HDL because they are not because they are excreted in the kidneys, and at the same time LDL is getting more dense, so we are having small dense LDL, and this is more atherogenic. So it is important to know that obesity is also inducing a kind of dyslipidemia that is called atherogenic dyslipidemia, associated with elevated triglycerides and low HDL levels. At the same time, the LDL levels are increased, but not so much compared to other patients that are having other kind of dyslipidemias. LDL is again what we want to reduce in this patient because it is causing atherosclerosis, and with we know that this is the major cause of coronary artery disease and stroke. So reduction in body weight with obesity drugs is important. And we have now new anti-obesity drugs that can be used and can be treat our patients with these drugs. We have the old drugs like orlistat, but now we're more using liraglutide, we are using semaglutide, and lately we are using tirzepatide for the reduction on body weight. You can see here that semaglutide is reducing the body weight about 15% from the initial body weight, and tirzepatide is reducing body weight from 15 to 20% of the reduction from the initial body weight. So these drugs can be used also for the reduction of cardiovascular risk factors at the same time that are reducing body weight. And what we know about SGLT2, we know from the studies from Giuseppe Mancia and co-workers that it is inducing reduction in 24-hour systolic and diastolic blood pressure. These drugs are reducing systolic blood pressure about 2 to 3 millimeters per mercury per 24 hours. Similar results for canagliflozin and also for empagliflozin. These drugs are reducing systolic and diastolic blood pressure. But at the same time, we know from the trials that they are reducing also 3-point MACE and heart failure in patients that are going to treat it for with these drugs in type 2 diabetes. You can see here the Canvas program with canagliflozin, similar results in the cardiovascular effects of these drugs. And as a result, SGLT2 inhibitors are drugs that can be used in primary and secondary prevention of cardiovascular and renal outcomes in type 2 diabetes. What about GLP-1s? Newer studies with GLP-1s show that these drugs are important factors that are reducing the cardiovascular mortality and morbidity in patients that are going to treat with these drugs, and these drugs are having now indications for patients that are having increased cardiovascular risk factors and type 2 diabetes. They are reducing AB1C, they are reducing body weight at the same time, reducing systolic and diastolic blood pressure. And several years ago, we did a consensus document in the European Society of Hypertension working group on obesity, and also with the European Association with the Study of Obesity, the ESO, that we can do more about patients that are having obesity and at the same time cardiovascular risk factors. Thank you very much for your attention.